We're here today to discuss building a health service that's fit for the future. There is obviously lots and lots of things being talked about in the media at the moment. Wes Streeting has announced his 3 shifts. So we're going to be bringing all of that thinking together, along with the 8 years of experience that Public World have, and Brendan and Septa have got together in this conversation to share with you the challenges, but also the wonderful opportunities and outcomes that can be had of moving to self-organisation. So it is my pleasure to introduce to you both Brendan and Septa, who are here to talk and kick the session off today. Before you do that, could I ask both of you to introduce yourselves to the group? If we could start with Brendan.
Good morning, everyone. I'm Brendan Martin. Lovely to see you all here. I founded Public World back in the day and continue to lead Public World. Public World works to support public service organisations, whether in the public sector or not, to develop relational services. That's to say, different kinds of relationships between themselves as organisations and the professionals within them, and the communities and the individuals that they serve. And for that, we believe that self-organised teamwork is very important, because working in that way requires high levels of freedom and responsibility for the professionals concerned. That's what Public World does, and that's who I am.
Thank you, Brendan. And Septa, would you like to introduce yourself?
Yes, good morning, everyone. I'm Septa Ham. I'm a semi-retired nurse. I'm working now with Public World. I introduced this new model of working at a large London trust, Guy's and St Thomas's, back in 2016 as a test and learn pilot, and was responsible for implementing an adapted version of the Buurtzorg model for about 3 to 4 years in that organisation. I have to say I haven't worked in that organisation for the last 4 years, so I'm not 100% sure what currently the situation is with the model that we did introduce, but I can talk about the learning. I hope that's helpful.
Brilliant, thank you, Septa. So the agenda for today, we're going to start with Brendan. Brendan's then going to bring in Septa with some questions and a bit of an interview. We will break out into small groups after the presentation to discuss together what we've taken from that discussion, and then we'll come back and we'll have a session of questions and answer and discussion. So, Brendan, over to you to get started.
Thank you. Can you see that? As my colleagues know very well, I'm not very confident with sharing screen. Can you see it?
We can see your slide deck. Yep. And that's perfect, Brendan. Yep.
Is it? Okay.
Yep.
Thanks very much. So what I'm going to just quickly do is run through a little bit about how we in Public World aim to work for change in public services, and particularly in the context of the 10-year plan that the Department for Health and Social Care, together with NHS England, is currently consulting about. And then I'm going to talk a little bit about our experience of working to introduce the Buurtzorg model, to introduce the Buurtzorg model into, not to introduce the Buurtzorg model, to work for change in public services, particularly health and care in Britain, in partnership with Buurtzorg from the Netherlands. That will involve a little bit talking about the Buurtzorg model itself, before going on to talk about our experience with the challenges and benefits of what we were able to achieve over about 8 years of our partnership with Buurtzorg. And that will segue into a conversation with Septa. particularly in that context, the experience in Guys and Tommies. Just start with a reminder. I'm supposing you can simply see the slides. Is that correct, Rachel? Rachel?
Yes, we can just see the 3 priorities for change slides.
Okay,
yeah.
great. Thanks. You probably all know this, but just as a reminder, I mean, I'm personally, I'm quite amazed about the idea of a 10-year plan, since the world is so full of volatility and uncertainty at the moment. And I know that a lot of NHS staff would probably like to be able to make a 10-minute plan, let alone a 10-year plan. Nevertheless, the idea of a strategic shift is clearly what's behind what the government's trying to do. And it includes you not only using technology more effectively, and that's a very big question, as everybody knows, but also what we would see as two very closely related shifts: a shift from hospitals to communities, and from prevention and from curative services towards prevention, which raises a more fundamental question, perhaps, than we'll have a chance to talk about today, which is, what is the NHS's role in prevention, given that we know that the social determinants of good health are so much broader than healthcare itself. But in talking about that, I was struck the other day by a quote I saw from the National Clinical Director for Improvement in the NHS, Dr. Shah, referring to the shifts that are being guided or planned, and referring to this as the biggest thing that has to be shifted is unlearning that NHS leaders, or indeed politicians, are the source of the solution, but rather creating the environment in which others can solve problems. And for me, that is really quite a profound and fundamental point, because what it suggests is that the role of government and the role of NHS leadership is to create the conditions in which the professionals working in the system, both in health and social care, are able to find the solutions themselves and in conjunction with the people that they're serving. And the way we might put that is moving from what we see as overly, and what we see, everybody knows that the NHS and social care systems are hugely complicated, partly because of the way in which they're organized for top-down, quite centralized command with a view to control, but we would say actually an illusion of control rather than real control. And what we would see as being important is a shift to a simpler framework in which the role of government and the role of NHS nationally is to create conditions in which the professionals working to co-produce and co-create solutions with the people they serve are able to work with high levels of professional autonomy and responsibility, but in a system of transparency, so that everybody locally can see what is going on. And for us, that way of working looks something like this, which is similar to the what Buurtzorg calls, Buurtzorg Netherlands, and I'll come on to who they are and what they do in a minute, refers to as their onion model. And what it's about is putting the person needing support, not only in the context of ill health, but in the context of preventative of work to prevent ill health and to enable people to live their best lives with a high level of well-being. That with that person and that person's needs and what's important to them at the center. Around them are informal networks of friends, family, neighbors, who are very important to draw upon, and SEPTA may have something to say about how this worked in the context of the test and learn in Guys and Tommies, to draw upon those resources with a view to building neighbourhoods of care that are more able to care for themselves with professional support, but without professionals replacing or substituting for what people can do for themselves and for each other in their neighbourhoods. And of course, the professionals in self-organising teams, in our view, need to be organised in self-organising teams if they're going to be able to work in the bespoke way that's needed for the uniqueness of every particular person needing support and the situation around them. That means that the self-organising character of the professional work needs to be able to enable those professionals to do what is needed when it's needed, to, as I say, not replace the role of the self-managing patient or client themselves with the resources around them, but rather to complement it both with, I'm not sure why that happens, both with the professional inputs that only a professional can provide, but also with the coordination, not least with the other services and other parts of the public services that also need to be drawn upon, whether it be housing, social work, or local economies. So that's how we see how to work in this preventative way and this neighborhood-based way. And as I say, it's very similar to the way in which Buurtzorg works, and I'll come on to that in a moment. To work in that way, as I say, for us requires high level of autonomy and responsibility, but not anarchy, of course. Autonomy and responsibility within a simple framework which expresses the shared purpose, the clear principles and agreed standards. And to support and enable that way of working through effective administrative services that are there to serve and support rather than control or command the professionals at in their daily work. So just to talk a little bit about Buurtzorg, the perspective I've just been outlining is one that Public World has been promoting for many years. But towards the end of my mum's life, which was in the early part of the last decade, I had a very close-up look myself at the home care services which were available when I was supporting my mum. And I could see that everything that I'd learned in my professional life about the need for higher levels of professional autonomy and responsibility for health and care workers, and how that could be best organized in self-organized neighborhood teams. That came together with my personal experience, and it became a bit of became my passion to think about how can we change the way that neighborhood care services are organized in Britain, in order to make them much more effective from the point of view of the people needing those services, but also much more enjoyable from the point of view of the professionals and more efficient. And so I went looking for examples of working in this way, and I quickly found Buurtzorg, which simply means neighborhood care, and is a Dutch social enterprise founded now about 17 years ago, and has grown from one team back when it started in 2007 to at one time around 950 teams. It's declined, it's contracted very slightly in the last 2 or 3 years for all sorts of reasons, some of which are obvious, but which has been incredibly successful in becoming the largest provider of neighborhood-based care and support in the Netherlands. Not only providing care of very high quality, but also jobs of very high quality, and doing both of those things at the same time as becoming increasingly financially efficient. And for us, it's important that it does, if you like, tick all of those three boxes. Very high level of quality of care, high level of employment quality, manifested in reduced turnover and staff sickness, for examples, but also very high level of financial responsibility, achieved in two ways, essentially. One, because of the Buurtzorg way of working itself, that is mobilizing as much as possible the assets of and the strengths of the people they're supporting and the neighborhoods and social networks around them, in order to reduce the number of hours of professional input on average per client, which Buurtzorg has now done by halving it from when they started. And the second way in which those financial benefits are achieved is that working in this way requires a very effective and efficient but lean back office and regional coaches to support the teams, but a much smaller and more nimble and agile administration than perhaps we're used to in the National Health Service in Britain. So that's essentially what Buurtzorg does. The model, as I say, is similar to the circles of support that I showed a little earlier, and this is the achievements that they've made. So no wonder there was a lot of interest in trying out such a model in Britain about 7 or 8 years ago, or actually nearly 10 now, when we started in Britain. And the way that happened was that we began with a chance meeting, which SEPTA might refer to, at a conference in London, which led to the work we did, the Test and Learn project with SEPTA and her colleagues in Guy's and St Thomas's, being the first initiative we took in partnership with Buurtzorg. And having got to know about Buurtzorg, I asked its founder, Jos de Blok, if we could work together, and he came and helped us he and his colleagues came and helped us with that work at Guy's and St Thomas's, after which they asked us at Buurtzorg if we would become their British partner, and we agreed to that, and we were working in partnership with Buurtzorg from then until last year. And as I say, a number of test and learn projects resulted from that. The picture you can see is of a wonderful trip we made with nurses from East London to Buurtzorg as part of the learning and development program that we supported for them. We also worked in those other places you mentioned, and in a number of places in Scotland, both in the NHS and in social care charities and social enterprises. We worked also a little bit in Wales and in a number of places around social care in England. And the range of these projects were from sometimes just doing some initial workshops to introduce some of the principles and methodologies that have made Buurtzorg so successful. And then the organizations would get on with it themselves in their own way, right through to ongoing programs of learning and development for teams and for organizational leaders and for coaches, such as we have done with, for example, the Thistle Foundation, with whom we've been working now for 5 or 6 years, supporting learning and development for about 20 of their teams, currently supporting the development of their back office into a much in a way that enables them to better support those self-managed teams. In other places, such as in Wales, we did a few workshops and they got on with it themselves in their own way. But the experiences and the challenges involved, although every situation is of course unique, nevertheless have been quite common throughout. And those experiences have been fundamentally that you don't have to be a Dutch nurse, or there is nothing very particular about Dutch culture that enables this way of working to succeed from the point of view of the people being supported or the professionals supporting them. And just to give you a flavour of that, we organised an event a few years ago at which all these people in the slide you can see are nurses and care workers from some of the organisations I've just mentioned. And we're just going to play you a short clip of the woman in the middle, Yasmin, one of SEPTA's colleagues at Guys and Tommies, who was a member of one of the teams that we supported with learning and development support there. Just to give you a quick flavour of what it was like from her point of view.
For me, it's having the time to care for my patient. And also I had example where patients were, they felt, there's nothing they could do for them, hopeless. And you see, it's like a beautiful flower, getting them from that position and getting them with help and support. It takes time, but I've been in a situation where patients with the team support, we got patients that were hopeless. GP thought there was nothing they could do for these patients and get them out of that depression. Just simple things. You didn't have to put any more resources, well, time maybe, and but having the named nurse, have one or two people have that continuity with that person instead of having many different people. But there's this beautiful examples I have, which you see someone from that dark place coming out of it, out like a bird and flying away. It's beautiful for me. And, it's helped me by the empowerment I've received to be able to empower other people, because I've got this knowledge, I've got these skills, it's there. So I want to share it, not only to teams, to patients, because it's not only the same for patients. If you get patient happy, you get the patient structured. It's the same for the team. You can transfer that vice versa.
Yeah.
And happy patient, happy team.
Yeah.
That's what it's about. For me.
But, and there always does have to be a but, what the biggest challenges that were experienced at Guys and Tommies, and we'll come on to talk about it in more detail, were not different there than anywhere else, and were really to do with how does an organization with lots of hierarchy, with lots of different departments, with quite a lot of complication in the organization, and with IT systems which are not well suited to this approach, how do you make that shift? And this is really important, of course, because firstly, it's impossible to grow this kind of experiment to scale unless you are able across the whole organization to create the conditions to support it at scale. So it's one thing doing quite a modestly scaled test and learn. You can find lots of get rounds, lots of micro solutions, if you like. But if you go this to a larger scale, you actually have to change organizational methods and systems. And so that was a common experience, not just Guys and Tommies, but practically everywhere. Which is why, for example, it's a bit easier to work with social enterprises and charities like the Thistle Foundation, smaller, yes, embedded in a broader system and accountable within that system, but then nevertheless with a certain degree of flexibility to be able to make the kind of organizational shifts that are required a little bit easier, perhaps, than NHS organizations are able to do. And this, as I say, was a common feature. But these challenges were not only at the organizational level, but also more broadly at the systemic level. One of the projects we took part in was just got in under the wire of Brexit, an EU-supported project where we worked with a number of organizations in Kent. And it's great to see Yvonne Wilson here today. Maybe she has some knowledge of what we did there. In Kent, we also worked in conjunction with Buurtzorg in Belgium and France too. And you can read the report of that project on the Public World website. We were one of the partners in that project, but they asked us if we would host the report. It's called a blueprint. It isn't really a blueprint, but it does have some really useful information and a digest of that information. There's just a 6-page chapter that tries to capture it all together, which I'd recommend reading, but also in very great level of detail, around 250 specific organizational and systemic challenges that were found by different organizations working in this way. And so that seems a good moment to stop sharing and to segue into a conversation with Septa. And I'm going to do that as soon as Septa reveals herself.
Brilliant. And just for everybody's information, we have put the link to the TIC project and to all of those results into the chat. So yes, welcome back, Septa.
Thank you.
Septa, nice to see you.
And you?
Septa, can you say something a bit about from the point of view of the patients that Guy's and Tommy's were supporting in the London boroughs of Lambeth and Southwark? I know that when we started working with you, you'd only recently, well, you can talk about it yourself, but I think it's quite significant that you'd only recently become the director of community nursing in Guy's and Tommy's, having yourself worked in the acute sector mainly before that, I think. So if you could say something about the origins and then of this and why you did it, but then also what you were able to achieve from the point of view of the quality of service to the people you were looking after.
Okay, thank you, Brendan. Apologies if anyone has heard this story before. I had been working at Guy's and St Thomas's for about, excuse me, I've got a cold, sorry, 14 years. And I had been head of nursing intensive care, theatres, imaging, and I've never been a community nurse, although in my nurse training in the 80s, I did do my placement in the community like everyone else, you know, that's a given. But I'd never, I'm a hospital-based nurse, but I think there was quite a challenge in Lambeth and Southwark. We district nurses look after something like 100 GP surgeries, so you can imagine the number of patients they had, and they were, for want of a better phrase, in a bit of crisis. And the the head of nursing at the time had left; she'd moved away, and I was asked to go and just cover for a couple of months until they found a replacement. Anyway, I'd only been out there about 3 days and thought, oh my goodness, this needs overhauling. This is, you know, it didn't feel very safe at the time to me. And excuse me, sorry, I did go back to the chief nurse and sort of raise my concerns to say that I was very worried about the situation and what was I expected to do. Probably the worst thing, because I ended up staying there for the next 4 years, which was very enjoyable but very challenging. And I tell Brendan this all the time. I saw this conference advertised which said district nursing in London, everything will fix everything. And I thought, oh, well, I'll just go to that conference and then I'll know it all and I won't have much to do and they'll have all the answers for me. I did go into this conference, which was being hosted by the chief nurse of London at the time. And they were talking about giving patients cups of tea at leg ulcer clinics. And I thought, no, we're in crisis. I've been working with a 25% vacancy rate. Just, you mentioned, Brendan, about there's nothing special about the Dutch nurses. What I did notice was that I was working with a very young transient workforce in London, whereas the nurses in the Netherlands were very mature and experienced and didn't really move on. So for me, that was certainly a challenge. So I did challenge the chief nurse at that conference to say, we're in crisis. That I don't want to hear about cups of tea at leg ulcer clinics. We don't have any district nurses. You've only trained 9 district nurses across London in the last year, and I'm working with a 25% vacancy rate. We don't, and the nurses do not have the time to care. That's what they were telling me. They don't have the time to care, and we need to fix this. So I kind of got thrown out of the conference. I was asked to leave, so I left. And on the way out, there's these little what were they called, Brendan? Breakout sessions, I suppose. So I crashed that one that said Buurtzorg nursing, and I went in. And there was 2 lovely nurses from the Netherlands presenting, and what they were presenting didn't sound new to me. That was very familiar to what I'd experienced in my training, putting the patient at the centre of the care, helping them to self-manage. And I think Jos de Blok refers to it as back to the future, and that's exactly what it was for me. I have to say, at the time, I didn't appreciate it. It was about self-managing teams as well. For me, it was the patient was the focus. And so I did that was on the Thursday, and I crashed Brenton's trip to the Netherlands on the Monday. And we ended up going there, meeting Jos de Blok. And I have to tell this bit. I stayed on a boat with Brendan and his colleagues. And when I was flying out of City Airport, my husband said, "Who are you going with?" I said, "I don't know who they are. I've only just met them a couple of days ago. I'm going with these strange men." And I thought, oh, but anyway, it turned out to be a very productive and fruitful and a great experience. So in terms of the patients that, and when we did I mean, there's lots to talk about around setting up and so on, but we did it throughout the test pilot. We did a survey, and we teamed up with Age UK and ended up doing this survey with a number of patients. And I'm just going to give you a few quotes from the patients. "The care the neighbourhood nurses give me is first class. Neighbourhood nursing should be rolled out across the country because my experience is absolutely wonderful. I think the nurses are the best solution so far to trying to keep people monitored and out of hospital." So that there are just a couple of comments from the patients. I think in the beginning, one of our ambitions was to reduce the number of visits that we were making with patients, and I think the nurses decided that they would try and concentrate on patients with long-term chronic conditions. And just a couple of, am I okay to tell a story or two, Brendan? Yeah.
Definitely. We want the stories, definitely.
Oh yeah, it's nothing like a story, is there? One of our patients was a Jamaican lady, and she had been bedridden for 10 years. She'd never left the house, and our nurses worked really hard with her, built relationships with her and her family, trusting relationships, drinking tea with this lady every day, helping her to, giving her the confidence to get out of bed, then giving her the confidence to sit in a chair, and then giving her the confidence to come downstairs. And we were rejoicing and celebrating when she got on a plane and went back to Jamaica to see her family. And that was a real win for us. We had another patient who was on insulin for 10 years, and we were visiting her twice a day to give her insulin. And after 6 months of working intensively with that patient, we got her off insulin. So that was another real win. Another patient, and this really gives a really good example of working with other partners in the community. So the GP for that lady, the Jamaican lady, the insulin lady, you know, working really closely with them, building relationships and networks with our healthcare partners in social care in the community. Again, another lady in the London boroughs hadn't been out of the house for years. I did go and see this lady myself, and she had a dining room table full of drugs, just randomly taking, I think, whatever she wanted to take. And we decided that the nurse and I decided that we would get in touch with the GP and ask if a pharmacist could come and review her drugs and do an assessment. And again, she hadn't left the house for years, and last thing we heard, she was in Brixton Market doing her shopping on a weekly basis. So again, another success story. And I just wanted to give you an example of one other nurse was, this nurse was looking after patient, real self-neglect. She was a patient on insulin as well, who had a partner with learning disabilities. Unfortunately, the lady deteriorated and had to go into hospital, and I think ended up having an amputation. But the team that was working with that nurse took on all her workload so that nurse could look after the partner with learning disabilities. Now, in the old days, the district nurse would probably try and refer to social services, and they would have to try and put a care package in, but she looked after that patient until, and then did arrange a care package for when his wife came home. So it's just an example of how the teams did support each other and what impact that had on patients. And of course, again, that trusting relationship, the husband knew the nurse and trusted her. And I have to say, that was a house, if you ever see these TV programs with hoarding, you know, lots of hoarding, I mean, the nurses arranged for skips to come in, for the house to be decluttered, and really changed the whole lives of those two people and their disabled son as well. So that's the sort of impact it had on patients. So continuity of care, building trusting relationships, and allowing and empowering the patients to self-manage. And I think that was real satisfaction for the staff.
And we thank you very much, Septa. And we heard that, of course, from Yasmin in that clip earlier. You mentioned a 25% turnover, staff turnover, when you began. With the increased job satisfaction that you've been describing, did it have an impact on that?
Yes, we eventually got our vacancy rate down to 5%, and it might be worth
5%.
5%, yeah.
Wow.
Might be worth, and I think eventually 3%. It might be worth pointing out that at the time, and I think you know the story, Brendan, when I took over, the CQC came to do a visit, and I'd only been there 3 months, I think. And as a department at Guy's and St Thomas, we got inadequate, which was devastating for me because, you know, you don't want to be associated with that. And but we worked really hard for the next 3 years, and the CQC came back and reassessed us in 3 years' time, the whole organisation, and we were the only department that got outstanding. So, you know, that was a real win for me. And probably not long after that, I left because it could only go one way, so I got out quick.
Yes. Yes.
So yeah, it had the whole thing. It was very difficult, but the whole thing had a really positive impact on patients and our staff and our relationships with the GPs. That was, you know, that was fun. I felt like the Antichrist when I walked into a room initially, and then interestingly, in COVID, one of our GPs was very ill, and I didn't have a very good relationship with him in the beginning. And he was very ill, and he ended up in Guy's and St Thomas's as a patient. And of course, he wasn't allowed any visitors. But I did, of course, I broke the rules and went to see him. Well, I was in the hospital anyway, in and out of the hospital. So, and he cried and cried and cried. And he, you know, and I just thought, oh gosh, we've come a long way in the last 3 years, you know, and we're great friends even today. So I don't know how I got onto that one. I'm rambling now.
Well, I'm glad. No, you're not. I'm really glad you did, because that story speaks volumes. And what it doesn't tell us, and we're not going to go into it, but I expect everybody can imagine that you describing this progress was really hard work, and sometimes really having to go up against many of the organizational obstacles as well as systemic obstacles that were in the way, and sometimes needed you to go and shift them, which of course sometimes is not the way to win a popularity contest in an organization. Can you say something about what you found were some of the organizational challenges of trying to create more favorable conditions within Guy's and Tommy's to work in this way?
I think it was a lot of hard work trying to share information with other people within the organization, to give them the confidence that we could try something different and new. And of course, they could not get their head around the concept of self-management. I used to say to the nurses, I mean, we all had to unlearn the NHS way of working, even myself. I love being the boss. I love being in charge. So it was like, even for me, I had to think, I have to sit back here. And actually, it was a light bulb moment when you sit back and listen to the nurses. The professionals, they know what they're doing. They've got the skills and they had the answers. So, you know, they will eventually get to a solution that is acceptable. And so for me, even for me, it was difficult to grasp that concept. And so I was in the thick of it. So expecting other managers in the hierarchy within GSTT to understand what was going on was extremely difficult. We had a really good senior manager who did go to Holland and have a look at it for herself, and she was very invested and very supportive. And that worked really well for me. And so you've got to get people on board. The rest of the organization, so I was trying to say, give the Burt's Org nurse or the neighbourhood nurses almost VIP status. So when they needed something signing off, prioritize it, you know, and the admin staff couldn't really understand that, you know, why are they having special treatment? They have to go through this process of signing off 100 forms to get a telephone, like everyone else. And that was, we were trying to break down that bureaucracy around just trying to get things operational. And that did work well because I had the support of some of the people, and GSTT did invest a lot of money as well into this. So we were, I did feel fortunate, but it was very, very difficult. And then when you start to operate at scale and you know, spread out, that too was difficult and challenging. And what I found was that we did set up a project board, and we did have a reporting system in place to give assurance to those totally against self-managed model. But I needed to give them assurance that, you know, as I said to the nurses, we wouldn't put patients at risk, we wouldn't put ourselves at risk, and we certainly wouldn't put the organization at risk, and that they had to trust us. So
yes, but not trust you, but not that trust is not blind trust, and it's not absolute trust. The project board played the role of putting in place a framework within which the nurses could self-organize. But that framework is really important because it defines the boundaries of autonomy of the self-organized teams, and it also defines the distribution of authority around the organization. And that's important not just for giving confidence to the whole organization and to the people it serves, but also to the team itself. Because what we found in other contexts where organizational leaders have taken the view of self-management that says, and one of the problems we found with working in the Buurtzorg way in Britain, indeed, one of the reasons we're no longer formally, you know, still friendly with Buurtzorg, of course, but no longer formally a partner with Buurtzorg, is the misunderstanding that many have that it's all about the self-management. But the self-management is actually an organizational methodology to create more favorable conditions for working in this relational way, because that requires high levels of professional autonomy and responsibility. And the responsibility exists within the context of that framework of standards. So I think it's very important to understand those boundaries and distribution of authority as well. One last thing before I hand over to Rachel Scepter. One of the other challenges about self-organized teams, where there is no hierarchy within the team, there isn't a team leader in this way of working, but of course there are more experienced nurses in teams than others. So of course you want to create conditions where that experience is a leadership that's able to benefit the whole team. You don't want to, it's sort of the equality of status within the team doesn't mean to say that you don't want the more experienced professionals or the ones with some special qualifications to be able to bring those to bear. At the same time, though, the pace, the remuneration systems within the NHS very much based on rising through the hierarchy. Did you, I mean, did you get a sense that that aspect of career development was a sort of systemic challenge to sustaining this way of working?
I think it was very difficult because you are right. It's promotion within nursing in the NHS is primarily based on management, and unless you're in a specialist role. So that was very, very difficult. We're supposed to be operating in a flat structure. And the other thing that was difficult, the nurses, if they wanted promotion, they had to leave the team and go to another team. So I had to work with HR and the organization to try and create a career framework and rewrite that. So, but promotion within the teams was based on skills and skill set and experience, which it was very challenging, and it was very difficult to get that across to the nurses. But we did work with them and we included them, and we got to a situation where people were rewarded for their skills and experience. And interestingly, if there was a team that didn't have an experience that a patient required, or the skills that the particular patient required, they would ask surrounding teams to help them, and you may get a nurse migrate across on a temporary basis to support that patient. So yeah, they looked at experience and skills, but we did have to rewrite the career framework.
Great. Thank you very much, Septa. I'm going to hand back to, there's going to be 100 questions. We're not going to have time for them all, but I certainly don't want to take up any more time before enabling others to jump in. So Rachel, back to you.
Thank you, Brendan. So yes, what we wanted to do was give you an opportunity to start your conversations and everybody have a bit of a space for voice. So we're going to break out just for 5 minutes, and you can obviously have the conversation that you want to have, but as a prompt, we thought that it would be useful to think about what you've heard today and how that connects with the work that you do, because you all do very different things, but also how it connects with those 3 labour shifts. So they're around the prevention, the shift to community, and also the technology that supports it, which we haven't probably covered very much today, but there's a lot of information about how technology can be improved. Doesn't necessarily all have to be replaced, but it can be improved. So they're the 3 shifts. So we're thinking about what Septa and Brendan have been saying and how it affects our work in those 3 shifts. So I've put you into small breakout rooms of 2s or 3s, and you're going to have 5 minutes, and then we're going to come back and actually just open this discussion up, have an opportunity to ask questions of Septa and Brendan and discuss what we've heard. So I'm going to open those rooms and send you all off, and we'll see you in 5 minutes.
Shelley didn't actually join me, Rach.
Oh,
I
okay.
think that the ones without, I think a lesson perhaps is when they haven't got their camera on, they might not be paying attention.
Everybody's gone. Nobody's. Oh, hey, here they are. Brilliant. You're all arriving back. So we've lost a couple of people in that. I hope they can get back in if that was unintentional. But we'd now like to open the discussion and hear from you and give you an opportunity to ask questions of Brendan, Septa, or indeed anyone else that might have something useful to say. So you can either do the old-fashioned way of waving at me, or you can use the react button and put your hand up, whichever feels most comfortable. And if it gets too quiet, I might have a question to ask if not. So does someone want to kick us off with some questions or some reflections? No.
Rachel, sorry,
Go for it,
I'll go.
Yeah, please do.
So myself and Mike Cribb, we started to talk, but we could have gone on for a bit longer.
Yeah.
I was just saying, and my friend Hamish on the call probably agree, but I've not done any work with NHS. I'd love to. I'm a systems thinking consultant, having done change with financial services. But I'm amazed at how much overlap there is. Systems thinking obviously works everywhere. But I was just sharing a story actually, and it's literally in the last couple of days. In the sorry, you probably all know this, right? But I went to see a dentist, and I went to lie down and try to look at my teeth, and thought it was going to be very specialist, just look at teeth. But she actually said, no, sit up and we'll talk, right? So I was amazed at that, and she talked about all my health, right? So I was thinking, God, this would be a brilliant way for the NHS to work. And only then did she look at my teeth, and then she said, oh, you need to do something with a different part of the NHS, right? So I said, oh, brilliant, okay, let's do that. And she said, no, you need to go to your GP. I said, oh, right, really? You've got the knowledge and the authority to do it, haven't you? And she said, no, I'm gonna have to, hand you off. That's what we call it in systems thinking, hand off. I said, oh, really? Because that means like I'd have to go to the GP and they'll just repeat what you've just done, right? And I gave her loads of praise. I said, brilliant, what you've done. You've like looked at my health. You looked at my mind. You looked at I have a neuro thing. She looked at everything, right? And she said, but I think this is what's causing this, that, and the other. And so I went to my GP. Sorry, you probably all know this, guys. I can only call them at 8 o'clock in the morning. They then have to triage it. Then it's 2 days until I get an appointment. Then I'll have to go in, and the GP will probably just repeat everything she said. And so from a cost perspective, it's obviously very expensive. It's repetitive. It takes time out of my life. It's probably delaying things, and perhaps things might get worse. So I suppose it's just a personal reflection that when I look at it with my systems thinking head on, I always do. I just thought I suppose I might be naive, but there are potentially massive improvements that could be made by giving a dentist just some more authority. And it could probably be done everywhere. Like, you go into the A&E and they could do a blood test straight away, right? Rather than, or that, I've got a million ideas. And I just wanted to sort of share that really, because I could see the massive cost. It's doubling the cost for the NHS. It's doubling the cost for me, my time. And it's probably doubling the cost to the NHS in the long term, because if I've got something that's going to get worse, then you're not doing the preventative stuff. And the other thing I just want to share really quickly, sorry, is that I worry when I see technology, and it has to be on a plan, but I worry that it's kind of everyone's obsessed with AI and everything. And if you automate a bad process, you automate a bad process. And I don't know if anyone saw, I can't remember his name, there's an entrepreneur on Question Time a couple of weeks ago. He said the very definition of the insanity is pouring money into a bad broken system, and that's what we're doing, aren't we? As a country, but hopefully not. You know, with prevention and community, maybe not. Let's be optimistic. But yeah, I just wanted to share that as a non-NHS person that hasn't done any work in NHS, but as a user, I suppose.
Yeah, brilliant. It's such a good point, Gary, and I'm sure we've all got examples as individuals that have been into the system in some way. Mike, I want to bring you in, and then Septa, I want to question you on whether you were able to address some of those permissions, whether there was any opportunity for you to give permission to staff to start shifting some of that. So we'll come back to you in a minute, Septa. But Mike.
Okay, I did a lot of work about 10 years ago with the change group at Warwick. It was horrifying. As a systems designer, it was the worst experience of my life. Management rules at so many levels. The things that are being talked about here, that Septa's talked about, that Brendan's talked about, for a systems designer, they're the complete obvious. You know, you've got professionals, you give them a very, very, very lightweight constraints because their professional training is already constrained them hugely. And their moral framework and the ethical framework and their ability to even carry on practice is already a huge constraint. They want to do the best for the patient. It's a total, unbelievable no-brainer that you need to do this. For those of you who think it might be airy-fairy, and I was quite suspicious of the public world thing because I've seen so many really awful self-organised teams, do their free course. Just do their free course. It's excellent. The guidelines they put into place, the training they put in place is really excellent. For someone like Andy, I know doing what you do, what you're doing at the moment, which is a very important lead-out job in training and looking at this sort of 10-15 year horizons. It's a really good model, Andy, if you haven't seen it, for how simple a system can be, but to provide what complexity theorists would call the enabling constraints to allow a system to perform. And I have to applaud Public World for doing a really good job there. Anyway, that's my bit.
Was not expecting you to say any of that, Mike. Thank you. Because there's a lot of hard work that's gone into creating that. But we'll come back. Septa, had you got any examples of when you were able to unlock some of those challenges that staff feel around just being able to make the decisions for themselves? And you're on mute at the moment before you respond.
Talking to myself. I think with regard to the care, the staff did feel very empowered. They felt very empowered to make decisions about patient care, and I trusted them to do that because, as Jos de Blok would say, if you give responsible people more responsibility, they become more responsible. So I always sort of went with that, and like I said, as long as they don't put themselves, the organisation, or the patient at risk, I will trust them to, and they didn't let me down. But actually, the nurses would say the block is the organisation itself. So they were very frustrated about trying to get a phone or a chair, or and part of the learning for me and anybody else going through this sort of implementation is make sure your back office is set up before you have an admin team at their disposal to be able to get things quickly for them. I mean, it was an absolute nightmare. They couldn't do their job because they didn't have a phone or a computer, or and the organisation did listen and did create a very robust back office and made the admin side, because nurses are not good at admin. Sorry, apologies to the nurses in the room. We just get too frustrated by it. We just want to do the patient care, and so making sure that's in place and unblocking things for them. That on the admin side.
Yeah, absolutely. The back office, sometimes it's mid office. So sort of training the head office staff to think in a different way, having a little siloed group that works in between, and starts to think about the nurses as their customers, and having a customer service ethos around how we're going to look after our nurses and enable them to do their job. That's something we've heard a lot of, and we've worked a lot with clients, and Kent in the TIC project did a lot of that as well.
Yeah.
So yeah, absolutely. There's lots of examples and small steps that you can take within your existing organizations without even needing to talk about self-organization. So the conversation around IT, the element of IT, it doesn't need to be a huge system change, but we can shift some of those permission giving processes where, you know, you need to get permission from your line manager, and the line manager needs to log in to give you that permission, which slows the whole process down. You know, if we can make some small, insignificant in terms of the workload changes, it unlocks so much, doesn't it?
So yeah, so each team had their own admin support, and if they got really, which is where the organization did support us, you know, but we fought hard to get to that situation. And you know, I think we ended up all having handheld devices, which made recording of care a lot easier. So when I always said, when a nurse starts, her phone and her tablet needs to be on her desk when she walks through the door, and each admin person made sure that was available to them so that they could start work straight away, basically.
Yeah, we hear a lot of that. Anybody else want to raise a reflection or a thought or ask a question?
Colin's hand is up, Rachel.
Oh, I don't know, I can't see it, Colin.
It's merged into that library in the background.
Okay. Colin, you're on mute at the moment, so.
Right. Thank you. Thanks, Rachel. And Brendan. Yeah, three quick points. One, which I've put in the chat. Brendan talked about the onion model and the outer layer of that onion being mobilizing neighbourhood, community, social supports for people in care situations, and lots of others as well. I just put some hard numbers on that. In 2016, or well, rather in 2018, but the figures they used were from 2016, the Office for National Statistics tried to do an estimate for the value of non-monetized work that goes into keeping us all functioning. You know, silly things like me running my son around in the car, or people doing laundry for each other, or whatever. And the figures were absolutely startling. It worked out at roughly the same size as the official economy. At the time, it was £1.63 trillion worth of productive activity going on, which wasn't monetized and therefore didn't appear in official GDP figures. But we see that during the COVID pandemic, when we had this massive upsurge in volunteering activity, which was basically mobilizing that sort of resource. So when I went down to the local Gurdwara for my first vaccination, there were literally dozens and dozens of volunteers there who turned up to help marshal people, do the car parking, monitor people after they'd had their vaccination and so on. So it's a huge resource potentially, which unfortunately our system of the welfare state, which has adopted the sort of nationalised industries model, which is and applied it to health and social care, really doesn't function very well in terms of involving that sort of community support. Closely related to that, Carol Power and I, it turns out, are both interested in co-ops. And one of the things I've been interested in recently is the degree to which we already have cooperatives working in health, social care and education in England in particular. I mean, for example, I didn't know until this year that we've got 300 cooperatively run schools in primary and secondary education. There's a lot of social care organisations that run as co-ops now. And both Labour and the last Tory government, for different reasons, have promoted the use of cooperatives. And I think that's something we ought to look at, because I think it's one of the answers to Brendan's question about the institutional barriers to self-management. One way around that is actually changing the organisational form to cooperatives. Last very quick point about IT. I think Septa's point about the basic IT system is absolutely right. It absolutely appalls me the extent to which the government, current government and previous government, have swallowed whole all this nonsense about artificial intelligence is going to save us all. You know, get some basic functioning IT and communications and administrative systems working first. Yes, AI is wonderful. Yes, it can do all sorts of interesting things. It can't change bedpans. It can't tell you who your next client is, particularly, you know, there's lots and lots of things that it just does not solve. And it worries me that that's where all the concentration's going at the moment.
Yeah, yeah. I hear you on that point. Ali.
Thank you. Just a quick point and related, Septa can probably tell the story. Septa tells to at least a couple of examples of patients. I'm thinking Septa, the diabetic patient who was blind, the son, and I think there's another one where by just having the time to have those conversations and to find out who else can help, there's been a son who is able to give the injection in the morning, or a daughter who on her way to work, when asked the question, said, yes, mum, I can pop in and do that for mum on my way to work. And Septa, if she wants to, feel free to add to that. So both examples of by having the time to have that conversation, you are finding support, which takes support of the professionals, which can be used elsewhere, and obviously reduces costs. And I think the final, very quick, some conscious time for me, is the cost thing. There has to be upfront expenditure, as Septa has said about the cost. It did cost a lot. In the knowledge that later on there will be longer term savings. And if we only ever plan and think about the money we've got in the pot now, it will never work. We have to. And again, with these teams, the best way is to make some changes, is to actually add some extra resource in the early days up front. Later, that will come back and the money will be saved down the line through number of visits that have been reduced. Septa can tell you all about number of visits they've reduced. Non-compliant patients that have become compliant, who they've just stopped visiting. And I'll stop there so Septa can say, but I think we have to understand that initially we need to spend more. However, our issue is we are living in an era where people don't have the money to spend what they need to spend now, and it's cost cutting. So to present an option which is going to cost more straight away but lead to longer is, people can't see around that. Except I don't know if you've got any more on those couple of examples I'd said, or that says enough.
Probably says enough. Just, I mean, I used to go out once a week with the nurses on my clinical visits. And yes, I saw that poor diabetic patient. And so, like I said earlier, we used to target the chronic patients and thought, we'll try and get them off the books. We'll try and get them to self-manage. And when we went to see this lady, I mean, the nurse gave her the syringe, and she had the syringe up to her eye. She couldn't see anything, and we thought that she's never going to be able to do it herself. So the nurse said, "Is there anyone else that can do it?" I think this lady her son was disabled who lived with her, so he wasn't competent to do it. But she had a daughter who was a dietitian who was going to work every day and passing the house, and we said, "Oh, do you think she could pop in and do your insulin for you?" And we called her and she said, "Absolutely, no problem. No one's ever asked me before." So, and then we didn't have to visit anymore. So, yeah, just thinking different and outside the box. In terms of cost, we did, as part of our project board, we did set up a whole board meeting around finance, and our finance directors did a lot of costs and analysis based on reduced visits and so on, about what we could save. I can't remember the numbers, but it was a lot. And that was one thing that obviously a big organisation like Guy's and St Thomas are heavily invested in. What's this going to cost us and how much are we going to save? So yeah, that was good as well. Good outcome for that one.
Yeah, brilliant. Thank you, Septa. Brendan, quickly to you.
Thanks. Honey, I'm going with you if you don't mind. She does mind. I just wanted to add to that. I mean, I remember an example early on, Scepter, in Guys and Tommies, of one of the clients that one of the teams was supporting had terrible leg ulcers, which seems to be a very common problem, and had not been out the house for ages, and was getting. And I think one of the important things to note about the evaluation that was done in Guys and Tommies is not that the evaluation found that the rest of the service was poor, but the quality, the characteristics of the neighbourhood nursing service, as it was called in Guys and Tommies, as opposed to the more conventional, if you like, district nursing service, was enabling this sort of very intensive work, which of course is expensive up front. So there was one example that really struck me at the time of a woman whose leg ulcers were being quite completely competently dressed whenever the community nurse came in. But this was going to be going on for the rest of her life because nothing else was changing. It was just being dressed very well. What the neighbourhood nurse was able to do was to create more favourable conditions for that person to become more mobile again. Of course, the immobility was itself leading to mental health complications as well. So it was all of those things were going on. By being able to spend that time up front to get to the root of the problem, that patient was discharged. So it's quite hard to quantify these savings, but they're there. And of course, when the test and learn projects were going on, because of the obstacles to getting to scale, it is quite difficult to measure the level of savings that are possible. But in the case of the East London, the Tower Hamlets test and learn, they did do an economic valuation, and it was a bit frustrating for Frontier Economics, who did that evaluation, not to have a longer term, longitudinal study to be able to look at. But what they were able to do was extrapolate from what was happening to what the savings were likely to be if this was able to continue. And that was an important piece of work, which I haven't got it to hand, but I think we need to promote that work more, because I think it's a very reasonable challenge to say, well, of course, if you've got more time, you're going to do better. But the point about having more time is that you're releasing time downstream and you end up saving resources and saving money. So I think where we've got evidence of that, it's so important that we address it. Thanks.
I would add to that a little bit on the leg ulcers, in that Michelle Willers, who formerly worked at Björtzorg, now works in our NHS and is an associate of ours, will tell you quite easily how leg ulcers are not a thing in the Netherlands. They're not a thing for Björtzorg. So if we quantified the cost of treating leg ulcers in this country, and then put in the system that Björtzorg uses and allows nurses to deal with it, that in itself is one massive saving, because they don't have those issues, because they allow the nurses to treat them in the right way for that patient, whether that be the type of dressing or the length of time that they need to spend with them, or the teaching that they can give them. There's, I don't know whether Septa's got anything to add on that, but Michelle talks so confidently.
I think it's about continuity. I think if you have the same nurse going in every day, assessing the wound, trialing different dressings, and getting something that's successful, getting it to heal. But if you, I mean, at one point, Guy's and St Thomas's did have a 50% vacancy rate. If you have agency and bank nurses going in, with the best will in the world, they're just caretaking. They're just going to do the dressing. They're not going to think long term, and they may go in once and never see the patient again. But the aim of the continuity is to heal that ulcer. So yeah, that's why it works if you've got the same nurse doing it.
Yeah, absolutely. I'm very conscious of time, and Ali's not necessarily going to get to speak, but we can follow up what she was going to say with email. But Mike, you were waving your hand at one point. Do you want to come in now? You're on mute.
Yeah, thank you.
Yeah.
Yeah, I'd just like to address one other dimension of this, that the cost savings over time are clear for all sorts of systemic reasons. But one of the things that SEPTA was, I think, rightly worried about, none of these people would let the team down or do the wrong things.
Yeah.
My systems experience is it's much more likely that a highly fragmented system will cause harm, because there are so many handoffs, there are so many cases of people giving up and then getting much worse, higher costs, giving up and dying, So, yes, one of the big problems in public life in the UK is we tend to think that if we control everything, it will be better. Everything will be marvelous. But if we over control and we fragment, then things are just a lot worse and a lot more expensive. It's so dumbly obvious. But the bureaucracy is a very well feathered nest at the moment, and it's hard for managers to give up jobs of control. And I think SEPTA said that of herself. It was nice to have control, and it's hard to give it up.
Yeah. Hamish.
I would just agree with what everybody said, but particularly Mike, work I've done and work of other people as well, you can cost account this really quite easily, but it requires a change in the way you think about money, and we don't think about money. Money follows activity.
Yeah.
And so therefore, if we do less activity, we save money, right? Well, no, you don't. You just create more total costs. For me, and I can speak for hopefully for other people as well, having done this or tried to do this work over several years, it comes back to, I think what Brendan said earlier, which is this work's actually about philosophy, not about the session with things like self-managed teams. They're a component part of the work. But unless we are serious about challenging the management practice and management theory, and the two are combined, and moving away from this obsession with activity management. I saw it only yesterday with my mum. District nurse came in. She's got 40 years worth of experience. She's counting down the days now until she can retire. Her quote was, the NHS has never, in my experience, her experience, never been in a worse state. That's about how we run the show. That's about how we manage this system. And we do over constrain it because we try to think that standardization and demand management and techniques like that will be the salvation. They're the opposite. And we've got to learn a different way of working. My other point is, sometimes we make criticisms also of things like new public management and stuff. This district nurse yesterday talked about a palliative care patient, that she wanted the GP of that palliative care patient to come out to see this person. They wouldn't. What she then had to do was make photographs and send photographs on a tablet device. That's got nothing to do with any new public management philosophy. That's just how you manage and operate a humane healthcare system, and that requires leadership. That's my view.
Thank you, Hamish. Ali, you had 10 minutes. I'm going to give you 2.
Seems a little unfair. Okay, that seems a little unfair, and especially as I've been putting my rants and raves in the chat box about social care and lack of beds, and how you wait on A&E for a bed in AAU, and then you wait for a bed on the ward, and when you get up to the bed, there's all these lovely old ladies and old men and other people as well sitting there wanting desperately to get home and being made worse by a system that keeps them there. So I've got lots to say on that. But just to say very quickly, one of the questions we always get asked with solutions and this whole, we've all said about it, there is so much here. Where do we start? And we get that with all of our organisations. We are passionate about change, and we'd love to transform the whole NHS and many other public services, but that, as we all probably know from sitting here, is not a work in a day. However, what we do believe in is very much small steps. And when we're asked by our clients is where to start or how to start, we say just get started. And that's come from experience and learning, because previously, we've tried to sell whole transformation programs, and that just takes, particularly in NHS, so long to sign off. But what we say now is just start. So whether it's starting with some training for yourself, so you as a manager, a line manager, a senior can make some change within your team, your department, whether it's just take on some learning yourself because you're in a team, you just want to know how to be able to have solution focused meetings and make better decisions. So we always say just get started. And to that end, our learning over the last 8 years has been summed up in our what we call our humanity at the heart offering. And very much we have a starting point for every organization, for every budget, for every client. It doesn't matter where you are, but we just say get started because we genuinely want to see that change somewhere. And more we believe in the ripple effect. And if we don't start somewhere and just start to see it all around us, it won't happen. So we don't want to keep speaking about all this great change. And I personally get frustrated by this. Another survey, this whole research from the, you know, this street in, and let's get everybody's opinions. Now, if any of you have gone on and tried to do that, I've done it. Oh, look, there's a few people laughing. I'm gonna sit there for days. So I did the main questionnaire, and then it says, have you got any ideas? Now, if you open that can of worms, you could do nothing else for the rest of your lives by just looking at what's been said, what you want to add to. I don't know what they'll do with that. I also can't believe that they don't know already those things. I know they do, and we perhaps think they're stalling. But don't get me started on that. Just to say, we will follow up with what we can do, and it's as simple as Mike isn't on commission, but maybe should be selling our free program. If you want to see the sort of learning that we provide, then our free course is a great introduction to self-organisation and to the platforms we use, and just that simple way that we're trying to share our learning. But we will follow up definitely with some information, and we're always, you know where to find us if you want to follow up on anything. We also have a series of events, the inspiration workshops like this, where we try and get one of our favorite people like Scepter to join us, because Scepter, it's by sharing those stories, those real stories that we believe will make change. We also have a monthly community cuppa, which is just really informal. It's an hour. Sometimes we have a question, don't necessarily have a speaker, but it's just turn up for an hour or any part of that hour, 10 minutes, and join in the conversation. Our next one of those is the community cuppa on the 20th of December. Christmas jumpers are optional, as are fairy lights, but you know, do join us with your Christmas cuppa and a biscuit and join us for a chat. It's 20th of December, so some of you may have wound down what you're doing or just fancy some time out to join us. And I think on that one, we're just going to chat about anything you want to, whether it's picking up from this or any bugbearers, or you just want to rant and rave about the services you've encountered. So please do join us. How was that for just a couple of minutes?
You did well. You took 3, but
All right.
I did
I'll try better.
shortchange you.
I'll try harder next time.
On that note, we have come to the end of the session. I want to respect your time and let you go. But I would like to say a huge thank you to Scepter for joining us today and sharing those really tangible stories that mean so much to all of us to hear them talked about. They can translate into the savings that can be made, but actually the stories are far more important in a lot of ways. So thank you, Scepter, for joining us and sharing. Thank you to all of you for joining in the conversation or just listening, if that's what's been right for you. That's fine. And thank you to Brendan for talking us through. We'll be in touch and have a good rest of your day. Thank you very much.